I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. As many people know, we are the only true open access journal in all of orthopedics, at least, where there is no article submission fee, no subscription, no article processing cost, and no fee for reprints. Um, I also like to say it, and there's no revenue. No, that's kidding. We're just tonight we have an exciting topic. I want to do a shout out, but it was become very clear to our advertiser sponsor, Stryker Recon, who has developed a remarkable product as part of a line of products that I recall when they first came out, the triathlon series. But the first thing I'd like to do is introduce our faculty. Tonight, I'll call on you and just tell us what you want us to hear about you. Andrew Wassef, tell us about yourself.
Well, first of all, thank you for inviting me. It's always good to be summoned by the Godfather. So, my name's Andrew Wassef. I'm from Long Beach, California. I'm in private practice, heavily weighted arthroplasty on really about 35% revisions.
Wow.
Do a little over 100 a year. Started a adult recon fellowship a couple years ago. So I'm the director of the LBOI Adult Recon Fellowship, and we it's perfect topic, something that's close to my heart, talking about hinges. We do a lot out here, and there's despite the many universities in our area, there's just a wide array of complexity out there that happens to find their way to my doorstep. So
That's great. That's great. Let's go to Nick Bedard. Nick, want to introduce yourself to everyone?
Yeah, great. Thanks for having me. This is my first JOEI session, so I'm excited to be here. But it sounds like a good group. So I'm at Mayo Clinic in Rochester. As a result, do a lot of complex primary and revision knee arthroplasty, and excited to talk about indications for hinge knee replacement. I think what we're going to talk about tonight is sort of how certain systems have expanded to kind of somewhat broaden our indications, not literally, but I think we can use these hinges in a variety of patients and successfully treat them for problems that may have been harder to address previously without good design. So excited for the session tonight.
Excellent. And Tim Lovell. Tim, I'd love for you to talk. I learned how to do an anterior approach to the hip from Tim, even though he is many years younger than me.
I don't know about that, but Ira, thanks for having me. And, I'm in Spokane, Washington, and we actually have the largest hospital in Washington State is where I practice. It's not in Seattle. And for over 20 years of my practice, I'm afraid to say how many years I've been in practice, but for over 20 years of it, 50% of my cases were revisions. Now, that's clearly not the case now. I've really tried to cut it back. But I love revisions. I love the challenge of them, and especially revision knee replacements, because it's fun to think about how to get things just right.
Excellent. So I want to make a comment to everyone who is on the call. If you have questions, the best thing to do is to put them in the chat. Then I will call on you, ask you to show your video, ask your questions. This is what we call an open mic session. If you have something to say, something to ask, there's no inopportune time to interrupt. We'll keep the discussions going. I'd like to start off with Andrew, just alphabetically. Okay. A, not the W. So tell me a little bit about what life was like before the new triathlon hinge.
So I'll set up a scenario for you.
Yeah.
Complex revision knee and trying to get away with a TS. And I have my whole back table. Everything's set up for a TS. And I'm about 50% through. And I kind of decide, okay, the MCL is incompetent, whatever the reason may be, I got to convert to a hinge. Now we got 13 trays to open. And I have a very unhappy tech, and staff is kind of running around with their heads cut off, and it's just really crazy. I'll tell you, I think the biggest thing for me is just the vertical integration. The new hinge has been amazing to be able to say, I got a complex revision. I'm going to start with a revision base plate. Anything else, even if I want to try a TS, I can try a TS. If I have to convert and, go to a hinge, it's only 3 trays. So it's extremely fast. It's very reproducible. And that vertical integration with just being able to stay in line has definitely drastically changed my operating room experience. I think for me, that's probably been, the biggest game changer. It's quick, it's very, very versatile, and it just feels like a normal TS revision system. There's really no extra steps on the tibia. I mean, very, very minimal. So, you're kind of flowing through it, and you really don't have to make a decision on hinge versus non-hinge until you're putting in the femur. So it's a really nice feature.
The feature. Nick, what are your thoughts about when you started seeing this system and the kind of cases that you wanted to apply it to?
Yeah, that's a great question. So I mean, full transparency, unless there's some sizing issues where I don't want to be quite as long, this is probably my go-to base plate in most of my revision systems and most of my revision needs now, because of that vertical integration that Andrew mentioned. Thankfully we don't have a ton of people after our revision knees that are falling and breaking their femur or something like that, but having that ability to mate a hinge knee or a DFR to your tibial tray without taking that out, especially in the era of cones. So having well-fixed tibial cones around your revision tray, and just knowing that you have sort of that ability to build off of that tray for the foreseeable future, for me, has sort of eased a lot of concern, or also maybe expanded my horizon a little bit for TS, because you're kind of between TS and hinge for the reasons Andrew pointed out, not just opening up trays, but like what you can kind of push a little bit. Like, is that too much laxity, or am I going to get away with this? It's a younger patient. Do I want to put a hinge in for the long term or not? It's reasonably balanced. It just gives you, I think, a sense of options and opportunity, and you don't have to definitively make that decision right before the case in the OR. And so for me, it's given some reassurance, and for that reason, that's been my go-to tray, even in cases I know I'm not using a hinge, because it's really no different of a base plate, and allows you to kind of mate things in the future. God forbid you have to come back.
So this is the universal base plate.
I do wish they fixed the naming in full transparency, because their old tray was called the universal tray, but that did not mate to the hinge. So the vernacular could maybe be updated, but there's a striker tray that can accommodate a PS or a TS, and then this new tray which will accommodate a TS or varus valgus constraint insert and the hinge or DFR, the whole entire hinge.
So the modification of this new tray, it's a TS and a hinge. EMRS.
A rotating hinge too. I think that's important to mix. It's not a fixed hinge through a standard tray. So it's still a rotating platform hinge built off of GMRS, legacy designs in terms of the articulation and the axle and everything that we liked about GMRS hinge in the past.
That's great. Tim, what are your feelings about the performance, the outcomes, the performance of this new tray, this new system? How has it changed a little bit of your practice? And you do a very high volume.
We don't have long-term results with it yet, obviously, but so far we've not seen any issues with it. And I think both Nick and Andrew pointed out some really relevant points, that when we go into revision, I always go into it with plan A, B, C, D, E, and F. And you definitely want to have at least one level higher of joint stabilization available than you think you're going to need. In other words, if you think, okay, I'm going to get away with a posterior cruciate substituting bearing, but I'm definitely going to have a constrained, in this system, a TS poly available. And if I'm going in thinking I may need a TS, I like to have the option of a hinge available. Right. Just in case. And so the system, as Andrew pointed out, is 3 trays. So it makes it very easy to have it available, number one. Number two, the eye to the future, as Nick was pointing out, it is really makes this thing in my mind invaluable, because when I put this tray in, I'm not worried if down the road this person falls, has a supracondylar femur fracture, needs a DFR, or something happens. I don't have to try to chisel out a well-fixed tray that has a cone in place. It just, the flexibility to me is what makes it really valuable.
That's amazing. I want to show us a couple of slides that were sent to me. I know you guys could see my screen, so I'll just do that. Everyone always asks, can you see my screen? Of course you can see my screen. All right. So I want you guys to talk about this for a second. Andrew, this would the severe deformity, this would be the severe primary, right? You would call I call those revision primaries.
Yeah, I mean, these are kind of no-brainers now for me. If I'm doing I had a case that was a 35-degree fixed varus, and a severe flexion contracture. In a patient like that, I'm going to use the revision base plate regardless at that point, and I'm going to shoot for a TS. But if I need to go, to a hinge, it's right there. It's easy and it's quick. And I know that, with some of these, especially some of these severe deformities, once you correct the deformity intraoperatively, a lot of times things feel pretty good. Sometimes a year out, things don't feel quite exactly the same, and I think anyone who's done enough revisions and has, I think, been critical of their own results has seen some of these patients where you come in and you're like, wow, that's not how I put that in, and maybe it's a big correction. There's the whole flap loosens sometimes, and sometimes you might have a semi-incompetent MCL or LCL, and so if you ever need to come back and convert that to a hinge, like Tim said, I've never worried about taking a femur out, but I've had really, really bad days in the operating room taking a well-fixed tibia out. So I think the morbidity of taking a well-fixed tibia out with a cone is just a disaster. But on the femoral side, it's really not that significant. It's really never been that big of an issue. So it just, in my mind, there's really no reason not to use the base plate. And I'm especially with the updated, one thing that they changed is the patellofemoral tracking. The old MRH, was a great system, but it was antiquated, and there was some to be desired on the patellofemoral mechanics. The patellofemoral mechanics now is a normal triathlon, so it's still a posterior condylar hinge, but it has the it's a rotating hinge, but it has the patellofemoral mechanics of a primary total knee, which I think for me, that's one of the bigger things I worry about in a hinge is really the patellofemoral mechanics and patellar instability. So it's made me a lot more comfortable in these severe deformities going to a hinge.
I'm going to ask Nick, and from the left side, picture 4, of course, a periprosthetic fracture. That's not exactly periprosthetic there, but would you use, let's talk about the use of this new system in what is now sometimes referred to as traumaplasty. It's sort of as we say in New York, a Schmeister knee, tibial plateau crunch down, the femoral condylar. Are you seeing those being shipped over to you in Rochester?
Yeah, I mean, I think short answer is yes. I think we being orthopedics, we're still trying to figure out what is the right indication for replacement versus fixing these fractures. I think it's obvious when you see it, right? There's a clear, frail, osteoporotic female with just a blown up distal femur that's probably going to do pretty well with a distal femoral replacement, and this system obviously can mate with that. And then you have the clearly fixable fractures that are going to do well once you get even with an interarticular nature. I think the in-between ones are always tough, and I'm not sure we'll 100% know that in the traumaplasty world, and there's a lot of factors that go into it. That being said, when plastic and metal might be better than plates and screws, this system I utilize for sure. Usually those are in the distal femoral replacement setting, but that, again, as we've said over and over, this new tray will mate with that. So it mates with the standard distal femoral replacement available through Stryker system. So it's again that vertical integration with these. But that fracture there, depending on their age and comorbidity status and what the CT showed for interarticular nature, may or may not get a DFR, but it's going to be a hard one to get to heal for sure in certain patients.
Right. So this is the new revision portfolio. Tim, do you want to take us through this a little bit? What's going on the left? What's going on in the middle? And what's going on the right?
Yes. Well, the on the left, you have a TS, the constrained poly revision. The middle is a straightforward hinge. And then on the right is the GMRS, the distal femoral replacement, with these new updates. And I agree with Andrew, the patellofemoral was always a little finicky, with the old system. And this has made it infinitely better. But the ability to go from what most people would call a standard revision, the one on the left, all the way across the board to the right, it's just nice to have the fully integrated system that you don't have to open the 13 additional trays. You can open 3 additional trays and make that decision midstream without freaking out your crew and taking 20 minutes just to open the trays.
Let me ask you guys, we've mentioned this idea about the 3 trays for a while. I want each of you to answer this separately. We'll start with Andrew. Do you keep this on consignment, this hinge system, or do you call people in to bring it? I mean, it's only 3 trays. I mean, it's no. What's your thing here? Yeah, who wants to go first? Andrew?
That's a tough. Obviously, this is kind of early release stage, and obviously they don't have a ton to go around, so things are being, things have to be shipped around a little bit. But for me, I always keep a TS and a hinge in my hospital, if at all possible. There's always, just because anytime you're doing a high enough volume revision knees, you just never know, right? You never know when something very unexpected is going to occur. You never know when an MCL is going to pop if you're doing a complex revision, or sometimes the balancing act is just not where you want it to be. So I think for me, if I'm ever doing a revision knee, I always have a hinge in the hospital. I just think it's a bad idea. I think what makes a good revision surgeon is preparedness, right? It's just not being caught with your pants down. So I always have a hinge if I'm doing a revision.
Nick, some comments on that?
Yeah, I would agree. I mean, I kind of joke, I work at the Disneyland of orthopedics, so we do have all this stuff available on the shelf by just the nature of some of the complexity that we tackle. But I think Andrew raised a good point. Like, even if you're not a super high volume revision surgeon, obviously, if you feel comfortable tackling the case, that's totally appropriate, but you have to be prepared. Tim mentioned this plan A, B, C. Revision surgery is my mentor called revision surgery is jazz. Primaries are classical music. You do them the same way every time as it's written. But revision surgery, you have to audible. You have to be prepared. You gotta go with what the knee's giving you. And if you're not prepared, you're gonna make that patient worse or at risk of making them worse. And so I think every single revision need a hinge in house, probably not, but you need to be thoughtful on the complexity of it, what you're doing, and what a reasonable plan A and B are going to be for that case.
Tim, biggest hospital in Washington, what do you got?
Well, we have hinge and GMRS in our hospital, but we have in stock the old system. So we still have to get brought in the new system, which, as Andrew pointed out, that would be nice, because if it was up to me, I personally would only use the new system. So in cases where I really think there's a good chance I'm going to need a hinge, I do have the new system brought in. But we have available the old one just in case. But I think, as Nick pointed out, you really want to think about what ifs in revisions, and so you can't just assume that you're going to get away with a regular old posterior stabilized poly, because in some revisions you're just not, and you want to have available one level of fixation to the bone as well as stabilization of the femur to the tibia than you think you might need when you're doing a revision. We don't, I was trained where same time as you, Ira, we were trained, try to avoid a hinge. Right. Because they didn't have the best long-term track record. Now, this particular hinge does have a very good long-term track record, but where we were trained to minimize the level of stability. And I think I'd be curious what the other guys think, but I think that thought process has changed a little bit now. That now, if I even think about, well, should I use a PS or a TS poly, I just use the TS.
Yeah, I would agree wholeheartedly with that. I think a couple things that have changed would be our confidence in metaphyseal fixation. Yeah. So the ease at which this triathlon system allows us to put in cones and the ability to obtain long-term biologic fixation, the risk of those transition forces to the bone cement interface is much concern. Also, when you start looking at, as we do more and more revision knees and we get longer and longer follow-up data, one of the most common causes of aseptic re-revision is instability. And so I never like to say never, but I can't think of the last time in a revision that I probably haven't put a TS in, unless maybe it's something unique with poly exchange for poly wear or things like that. Because if I'm confident with my balance, then the TS is just a belt and suspenders and my ligaments are taking the stresses. And if it's on the fence, then I'm relying on the constraint and then the metaphyseal fixation for the implant fixation. So, and we got reasonable data on that varus constraint in contemporary designs with the metaphyseal fixation is risk of loosening is quite low. You're going to fail with other mechanisms before you have a loose implant with a well-done revision knee.
Yeah, I think you kind of hit the nail on the head. I mean, it's that zone 2 fixation with the cones I think that's transformed all of our revision practices. I mean, I can't remember the last time I did a revision without using a cone, especially on a hinge. I'm always using a cone on both the tips and the femur is actually, when I was in fellowship in 2012, I was with Ed McPherson, and I think he was a little ahead of his time in terms of he went to hinges. He always thought, don't worry about the constraint. You need the constraint. And so we did a lot of hinges, but we all, we saw femoral loosenings, right? And so that was always the issue. There was no good cone fixation. Now, I mean, that's really transformed, I think, our results, and we're not worried about the loosening. So it's made us much more comfortable going to that higher level constraint when needed.
Amazing.
And Ira, I think.
Yeah, go ahead.
Well, I think this is a good point because when you and I trained, the trend was for long uncemented stems, right? Yeah. And I clearly have seen the transition more to getting epiphyseal, metaphyseal fixation rather than epiphyseal and diaphyseal. In fact, I think, Nick, it was a Mayo Clinic study years ago that your guys' 10-year follow-up of revision knees showed better long-term outcomes with short cemented stems than with long uncemented stems. And so using cones, as Andrew said, I use cones almost every single revision.
Guys, can I have a quick question? Can I jump in?
Yeah. Then go ahead.
Are you guys typically putting cones on both sides or just tibial side? If there's no significant bone loss, let's say it's a pretty straightforward revision.
I'll jump in. I'm putting cones on both sides. I mean, I guess, maybe a uni conversion, something like that, or a debonded.
Yeah, just a standard, total going to a revision.
Total going to another total. I'm putting cones on both sides with this system. I think you can slip a small 1-2 central femoral cone in with pretty minimal additional bone removal. The reason being is that, I'm growing up in the home of cones. And so we see a lot of cases where, a good rotational capture, cone wasn't put in 10 years ago. The problem was on the tibia, big, huge bone loss, big cone. And 10 years later, the femur's loose. And I'm not saying that's like, 20% of cases, but I do think that metaphyseal fixation goes a long way. And so unless I'm worried about it compromising, taking the bone, or it's a small little, size 2 femur or something that I'm worried about, for me, I'm slipping the central cone in on both sides in 85-90% of my revisions.
How about taking cones out?
So
yeah, exactly. Right?
Well, so I think this is something that's changed since we first started using cones. When these particular cones first came out, there was a tendency for most of us to go big, and just because of the question you pointed out, I have now gone to whatever it takes to get good cone contact with bone. But ideally, I like to go a little bit smaller so that I can get the Midas Rex with an S1 tip all the way around to burr out that cone if I have to. Does that make sense? So that's one of the things that we've seen is we're going to a smaller cone rather than a bigger one, given the option. Now we still want to get good contact to host bone. So I don't really want to compromise that. But rather than just trying to put the biggest one in I can, I try to go with the smallest one that gets good host bone contact for bone ingrowth.
I think a lot of us are also kind of insetting the cones when there's, if I have a tibia that's pretty supportive and I can lay my base plate on the tibia and not just the cone, then I'll inset my cone just a little bit. So that way, if I ever did have to come back, I could kind of get in between the base plate and the cone just to at least break down that interface. And, we've all been in those, we've been in infected revisions and had to take out cones. And it's, I think you just have to understand it's a bad day and you got to accept it. And you got to, and the funny thing is, the first thing you'll say is, I'm not going to use a cone. And then the next revision, you're throwing in a cone because you know it's better, right? You just know it's optimal fixation. And I see a lot more. I mean, I do way more revisions for loose revisions out there than I do for infections, although I mean for infected revisions. So I mean, I think it's, as long as you're comfortable doing that next stage, I think it's a no-brainer to use a cone on these revisions.
Yeah, I think getting cones out, in my hand, getting cones out is actually easier than getting sleeves out because how wide to get a good sleeve in, usually you're pretty big and you're way, especially on the femur, you're way out into the condyles. And it's very hard to get that angle right without kind of cutting through and then breaking off a condyle. So yeah, big, huge cone, perimeter cone on the tibia or the femur, that's a tough day. And that's going to be hard no matter what. But central cones, being thoughtful, disrupting the interface, taking your time, disconnecting the two things. I mean, it's a pain it's pain, but it can definitely be done with relatively minimal additional bone loss.
Yeah, I just want to make a comment as a chairman who has to look at purchase orders once in a while. Whenever I've been seeing cones like crazy, and I turned to my rep and I said, I don't get it. Why are you charging so much for cones? And I showed him a picture of some sugar cones from Stop and Shop. I said they're only $1.49. I mean, what are you doing to me here? But they do make a very big difference. Obviously, it's been a big game changer, the cones. There's a question by Brian Adams. Brian, you want to unmute yourself and show us your video and ask your question, Brian? Okay. Brian Adams. All right. Well, he said, any tips or tricks for prepping the smaller tibias with the new revision reamer? They have a hard time getting to a B cone in those small tibias. That's the question. Anyone want to take that on a little bit?
So the only trick I have is that rather than put in a tight tibial long straight reamer, I a lot of times will use the starter reamer or one that clearly is not engaging the diaphysis, so I can cheat that the long reamer. I can cheat it to wherever I have good bone, and I don't feel like we have to have these metaphyseal cones perfectly perpendicular to the mechanical axis. So I will put in my guide reamer, if you will, very loose, and then when I ream for the cone, I just move it to wherever I can get the bone reaming that I need, rather than have it be dictated by the distal reamer.
Yeah, I think I do the same thing. I always use at least, if I stopped reaming at like a 14 reamer, I'll when I go to the cone, I'll go down to like a 12 or an 11. I'm always using a smaller reamer, so that way, and it's almost always kicking you anterior, and you're worried about reaming out that anterior cortex. So then I'll kind of at least be able to push it back posterior, get it in the bone I want. If it's a truly really small tibia, sometimes I use my cone as an augment. So sometimes I'll leave my cone proud and I won't actually go to completely dunk my cone. And, I think that's fine as well. I've had plenty of cases where I'm resting my base plate only on my cone, and I don't worry about that fixation at all. I think it's still very, very solid fixation.
Yeah, I mean, just to hit home the same thing. The beauty of the cones, the on-linked metaphyseal fixation between the implant and the cone, the beauty is that the cone should not dictate your implant position. So you can, same thing on the femur. So you got to be careful, right? If there's no bone anteriorly and you're kind of not trying to ream into the posterior, your reamer can get carried and you can anteriorize your femur. You're going to have to work to place those cones into the bone so that it doesn't dictate your implant fixation. Or implant position, excuse me. So you can adjust just like they said, you can ream even freehand. I agree with Tim. They don't have to be perfectly mechanically aligned cones. The x-ray might look a little goofy, or you can have a little slope or even a little reverse slope on your cone. And you want bony contact, and then to be able to put your tibia or your femur where it's designed to be, or where you want it to be for the ligamentous balance or the knee function. But yeah, you're gonna have to cheat a little bit. The small bones are hard with any system and any revision knee, because to accommodate a hinge, to accommodate rotation through that, you need a pretty big boss. You need a pretty wide proximal tibia in order to get that implant in there. But you can make them fit and you can work it, and just got to be cautious. You can't just blindly ream off your own reamer down into the ankle, or else you're going to end up in a lot of weird positions on that tibia.
That's interesting. Interesting. Let's talk about Disneyland again for a second. You brought that up. I was just going to say, we have 6 complete sets of this new thing. What are you talking about? And we're in the South Bronx, Andrew, what's going on here? You're in South LA, No, I'm just kidding.
Hot commodity.
Yeah, hot commodity. So do you see a future for complex knees being done in an ASC, taking away price for a second? Let's just say one day the insurance companies pay the implant price in an ASC. Okay. Take away price. Reasonable to consider doing this hinge in an ASC?
Yeah, I mean, the short answer I would say is yes. And the reason being is, I'd love to just say it's because of the great implant design. The reason is the advancements we've seen in arthroplasty, particularly in our primaries, but it's now translated over to our revisions in pain management pathways, perioperative optimization, anesthesia, mobilization, blood loss with TXA. It is much safer, and it's become to get people out of the hospital sooner.
Yeah.
So, it's not like I have a ton of same-day discharge revisions, but we're starting to see more of that, right? You got a younger, healthy patient. It's got a relatively straightforward, maybe a debonded, tibia or something, and a relatively straightforward revision. If they're passing the metrics and they're doing well, I mean, those patients for sure are leaving within 24 hours at our shop. And I can see a future where a appropriately optimized patient with a good care pathway and a relatively straightforward thing. I don't think the surgical burden and revision is as big as it was. Now, I think whether or not they can go home the same day and be in an ASC less relates to what we're doing surgically and more relates to their comorbidity profile and their health and the anticipated blood loss and all that kind of stuff. So do I see it being a high percentage of them? No. Do I see more and more kind of straightforward revision, especially on the hip side? I know this is a knee talk, but headliner exchange, isolated acetabulum revision or something like that. I could definitely see those being done in outpatient setting in the future.
All right. Tim, you said you had a case for us. Yeah.
Well, so I just wanted to show. Let's see. Is this showing up there, Ira?
Not yet, but it will.
How about now? Can you hear me now?
Yeah, I hear you, but I don't see the share screen. The green button, share screen.
Yeah, I've clicked on it and
share your desktop.
Okay, I'll try it again. Share screen. Let's see, we'll try that one. Is that working?
No, foiled again.
Foiled. You know, I love technology when it works.
I know. I know. So I'm going to change gears for a second while you figure that out.
Yeah.
And this is this, I'm assuming this is an accurate slide because I believe it came from Stryker. So I'm giving them the benefit of the doubt. Okay. Those are the three trays we're talking about, the bone preparation. All right. Tell us a little bit about trialing with this new system versus the old system, trialing the polys. Because I remember with, with the old hinge system, if you don't really balance it well enough, you have some problems, with liftoff and stuff. So how is the trialing on the tibial side done? Tim, any comments on that? Or
It's easier. As you can see, it's easier to slip in these different, I don't know what you want to call them.
we call them shims. We all call them shims.
Shims. You can slip in a shim, and it just makes it easier, quicker to try it.
And you can also see that that femoral tibial groove there on this picture a lot better than the old femoral groove, right?
Yeah, I think the harder things to do, at the end of the case when you're trialing is have to disassociate the entire hinge every time you wanted to change a poly size. So, this shim system, now you don't have to. It's one poly, then you trial whatever size you want just by going in and out with the shim. So, I can trial 5 times and it takes me about, 3 minutes. There's no time involved. So I think that's one huge benefit. I mean, anyone watching me and my PA trying to disassociate the femur, put it back together, and me looking at him like I want to kill him because he can't get the femur mated just right, and it's not easy. It's just not an easy task. So I think it's taken out a lot of the frustration. And then that trial cutting guide that you saw, that bone preparation, that TCG guide is, I think on the hinge side, I think it's just an amazing,
You're talking about this.
Yep. So
talk about that. Yeah.
Yeah. So that TCG guide, basically, like, say you already have everything cut for a TS and you decide I want to go to a hinge, you could just slide that on, and all you have to do is make those final cuts through that. Wow. Now, even more importantly, even if you're going to a hinge from the very beginning, what I base my joint line off of is where my patellofemoral articulation is. So if I'm doing a severely arthrofibrotic case with, patella baja, I'm not putting, I'm not using the kind of old school measurements of using the medial epicondyle 3 centimeters and doing that. I'm using where's my patella sitting, and that's where I'm going to judge where my joint line is. And that cutout, actually, that TCG guide has a cutout for the patella. So it pretty much shows you where your patella should go. So you could pin it, establish your joint line, take it through range of motion and trial with it. And then once you're happy with it, you just do your cuts through there and that's it. And then release your ligaments and you move on. So it's an extremely fast preparation on the femoral side.
Yeah, I agree. And one thing that's not on here, and we're not doing a ton of primary hinges, but we did talk about some of those indications for that, is something as simple as a spacer block. But I think it's really helpful, as done a couple of these primary hinges, is when you resect your tibia, you can put the base plate in and you can quickly make sure you've resected enough distal femur, because in a primary hinge, the tendency is to under resect because it feels like you're taking a lot of bone off, and then you get all your trials in, and it's not that it's too tight. You took the collaterals down, but the joint line's off, the patellofemoral kinematics are off. You need to maybe raise it or distalize, whatever you need to do. And so they have some just slick, quick checks where cutting a little bit bigger tibial cut, put a spacer block in there that's defined as the minimum resection from your distal femoral cut, and you can just make sure you're there quickly, and then slap on that cut through trial, and you're off to the races. So they've really streamlined the ability to put in what was historically is a kind of a complex implant to put in, cutting these hinges and getting it down. It just made it more efficient, which just makes the operating experience that much better.
Amazing. Question about this. You talked about classical music versus jazz. So in class, I'm taking all your quotes here, Nick.
I like it. I like it.
I will reference you where.
Well, Dave Llewellyn, you gotta give it. He's the one that told me that, so I'll give
All
him
right,
the
all right.
real credit. Yeah.
All right. So David Llewellyn, channeled through Nick Bedard,
That's right. There you go.
said, so certainly in classical music, you can use a Mako. You think we'll get to a point where you can use robotics for these types of cases, or is it really it's really going to be the art of the surgeon?
I think there's going to be a role for improved, I'll call it navigation, robotics, and revision of the arthroplasty. I mean, I think there already is a role. We just don't have a great application for it, or maybe not a great application. We don't have a great way to enact it yet, because I think there's always going to be some art. There's always going to be unanticipated bone loss. There's going to be bone loss with implant removal, but I think as technology gets better and we have better fixation strategies, we're going to be able to be slightly more liberal with our implant alignment and positioning. So I'm not talking about kinematic revisions, but I am talking about when we're a slave to the canals is
Yes.
when we're going to end up with a little bit of valgus, or we're chasing that lateral laxity because our guides are our diathesis on our tibia and our femurs, and we know bend and bow and curve on everybody differently. And so I think with shorter, in my hand, shorter cemented stem fixation, metaphyseal cones, it's going to allow us to judge our implant, change our implant fixation slightly. And I think navigation and robotics are going to allow us to be able to do that accurately. Right now, we're just a slave to the instruments we have and the guides that we have. But there's going to be a role for that for sure as we move
100%
forward.
agree.
Yeah.
100% agree.
Okay. So let's expand on that. By the way, before we even continue that expansion, I am going to share my screen. And does that look familiar, Tim?
There you go.
All right. All right. I've reached
go.
across the country through Erica De Leon from JOEI. And tell us about this case.
Well, this is sort of what we were talking about at the beginning. This is a 71-year-old lady who actually both of her knees look just like this. And these are fixed varus deformities. And I thought for sure I was going to need a hinge because I just did not think there was any way I was going to be able to mobilize that MCL, stretch it out enough without, my impression with the MCL especially is when you're trying to balance a case like this, it goes good, better, dog, do. And so you can see that I ended up using this new tray along with I recreated part of her medial tibial metaphysis with an asymmetric cone, but anticipating that I was going to need it. And it turned out, again, surprisingly to me, we did not. We were able to get her very stable with even a posterior stabilized poly. But I think as Andrew pointed out, and Nick, if I even think about it, and there was no question in this case, I was planning on using a TS poly if I didn't have to use a hinge. But to me, this gives me the comfort going into this case that if I need to change midstream and put in a hinge, no problem. It's very quick, very easy.
Andrew, some comments on this case? You'd handle it the same way, probably, right? What do you think?
Yeah. No, I mean, I think this is a great reason to use this revision base, but I think this is kind of a no-brainer. It looks great. I mean, you've restored. I mean, being able to restore her function and give her, the constraint necessary with just a TS, that's fantastic, right? I mean, if you don't have to go to a hinge, as much as I love hinges, there's a time and a place, and if you don't need to go to a hinge, this is just a great reason to use this. And if you ever had to convert it to a hinge in the future, it's really not a significant burden. So it looks great.
Well, I honestly thought I was going to use a hinge. I was pleasantly surprised that I did not need it.
Yeah.
I always look at these cases and I look at the pre-op and I say, this didn't happen overnight. What was the patient thinking 6 months ago? Like, yeah. Or
now, is this a case that you would have started using Mako with? Would you start with Mako and then convert, or?
Well, I did use Mako on this case, but I don't know if this was one of my first 5 cases. Although I full disclosure, I think my 3rd or 4th Mako case was somewhat similar to this. So, but in general, I think we would recommend people ease into it. But Nick's right. I think we'll be using robotics for revisions in the future without question.
Right.
What I like about that case, IRF goes up,
Yeah.
is just to highlight the cones. I know it's a hinge talk, but the
Yeah.
ability to use cones for both, in this scenario, rebuild and to get fixation for this, especially in a case with complex anatomy. But this is also a case where somebody had asked Brian or others when it's a little harder to fit everything in there. It's a primary knee, although a lot of bone loss. We can talk about on or off label, but you didn't need to go all the way down in there with the additional tibia or the additional stem on the tibia. And so those, if the tibial diaphysis had a little bit more bow, and maybe that's a case where Brian's kind of running in things that, you can accommodate different ways with some interoperative off-label ways to do it. But this system allows you to address these bone defects, allows you to be modular. But the cone is a perfect case for rebuilding that metaphysis with the cone, but still getting good biologic fixation along the lateral side and probably anteriorly as well.
Ira, what's the range of motion? What's the range of motion post-op? Pretty picture. What was functional?
Oh, she full extension, and last when she was at her 6-week post-op visit, she could flex 120 degrees.
Wow.
Pretty impressive.
She was pre-op. She had good motion.
She had reasonable motion pre-op, and she's motivated. She's, some people, their motivation may be not as good as others. Maybe is that politically correct way to say it?
Yeah,
she's motivated. She's motivated, and she was 0 to 140 at her 6-week post-op visit.
So this is a posterior capsulectomy, lobotomy?
No. So what we did is we really stripped most of the MCL off of the posteromedial and the medial cortex there on the tibia, and just kept working on it. I normally, one of the ways I like to deal with some of these is put a little bit of varus into the tibial component, but obviously I'm already right up against the lateral cortex distally with a stem. That's one of the reasons I really didn't want to put a stem extension on that. It's kind of hard to tell, but another thing that we do very commonly in these is a medial reduction osteotomy, where we will take off part of the medial tibia, go with a smaller size tibial plate, tibial base plate, and that is I look at it as I'm taking off more than just the medial osteophyte, and that also helps lengthen the MCL. Again, honestly, I was expecting to have to just release the MCL completely and have to go with a hinge with this, but I want to show this, that by having this base plate available, it's very easy to accommodate whatever decision you need to make intraoperatively.
I know Nick mentioned about this being a hinge talk, but it's really a revision talk. But tell me about that asymmetric cone. It looks, in the olden days, you'd have to cut a box and do a couple of augmentations, 2-centimeter augmentations, box augmentations. But now you have this asymmetric cone. Tell me more about that.
Well, so if you look, her defect, you can kind of see it on the pre-op films. It's posteromedial is where she's missing most of her bone. And so that was where we were able to put, if you look at the post-op AP, you can see it looks like there's still a little bit of medial tibial cortex there, but where we were able to put the augment, it allows enough rotation to get the tibial rotation right that I could use that to try to create part of the posteromedial tibial cortex. And this is where so I've done this multiple times, using it to recreate the medial tibial cortex or even the lateral tibial cortex where it's just gone.
Yeah.
I mean, I think the original cones, when they're designed for the most part, was to rebuild missing bone. You think of these big, huge perimeter cones, some of the initial designs from any of the companies that came out with them, they're super big or wide. They go out to the cortex because it was to rebuild. It was to make up for bony allograft augments that weren't working. And now the cones have gotten smaller and smaller because there's another philosophy, and it's to use cones for fixation. Sometimes it's both, but there's to rebuild, what Tim did here, but he also used it for fixation. And so the perimeter, the asymmetric portion, that's the rebuilding of the bone loss. The most of the fixation is still coming with that cone centrally within the canal. The other side just supporting the implant like an augment. Sometimes you have to stack cones. The top one's not really for any fixation; it's to rebuild, and then the more distal cones are to get the fixation. So as the smaller cones, the ones easy to remove, the ones we're talking about, those are the ones you're just slipping in. You're getting a little biologic ring of fixation in zone 2, but you still have the complexity of the cones to address bone loss in terms of rebuilding metaphysis.
The cones have truly revolutionized our ability to do revision knees. They really have. You mill them, machine them, whatever you want to call it, and that has been, for me, one of the biggest improvements in revision knees, I think, in my embarrassed to say now 31 or 32-year career.
Oh, I didn't know you were so young on that one. I was like, I thought you were my age. Andrew, what are your thoughts? We're gonna sum up. So I'm gonna go around at like every JOEI seminar, every JOEI topic session. It always ends faster than you think and faster than you want. All right. But before I go around the horn, I'm gonna introduce Kevin Plancher and for a shameless no, he says no, don't. Ortho Summit is coming up from September 13th to the 18th. An amazing course, a lot of revision stuff going on there. And Kevin is of course, the founder and the force behind Ortho Summit. So and you can still sign up to Ortho Summit with the OSET JOEI motion code, which gets you a big discount.
I recommended Ira because the prices went up. So take advantage of tonight. Look forward. We want to thank Ira. He'll be leading the way for residents and fellows and the arthroplasty section and doing a lot. He makes a difference, and his journal will be there. So join us. You're not going to beat it. You want a keynote speaker? I'll surprise you to say that the lady that you wear scrubs sometimes, Figs, Trina Spear, will be highlighted in her entrepreneurial ways on Saturday, just signed. Andre Agassi will send some thoughts on Monday. Mike Ruzioni, Miracle on Ice on Tuesday. Joe Theismann on Wednesday, and Great Science every other day. So,
all right, that was a good shameless plug. Now we're gonna thank you, Kevin. I'm gonna go around the horn. Start with Andrew. Give us a little bit of just a summary of what we've talked about a little bit today, and where you think maybe the future is going to be in the next 2 or 3 years.
Yeah, I think you've heard from all of us. We're all much more comfortable with different levels of constraint now because of the fixation that we get with our cones. I think, looking at hinges, there's just so many indications for hinges, I think, in a revision setting. I mean, any extensor allograft reconstruction I'm doing, that's an automatic hinge, and having a posterior condylar hinge where there's no reported dislocations in you can look through the literature, there's 0 dislocations with a posterior condylar hinge because it takes so much of that pressure off of the patellofemoral articulation. I think is absolutely a home run for those extensor mechanisms. Recurvatums, post polios, there's just so many reasons I think that we're finding people do better with a hinge. So I think you'll see this, becoming more and more in the future.
Tim, some final thoughts?
Yeah, just to keep it brief, I think Andrew and Nick did a very nice job of pointing out the highlights of what makes this an easy system to use and to be able to transition easily from your various levels of constraint. It has made it a much more user-friendly way to deal with difficult problems.
And Nick, from the winter wonderland of Rochester, Minnesota, I'm going to ask you to sum up and bring us home.
All right. Well, I think the take-homes for me and for our group here is always have a plan, A, B, and C, going into a revision. You want to be liberal with your ability to achieve stability, because these cases, they'll loosen up. You don't want to have to come back. You want to solve the problem at the time of the revision. When you get into multiple revisions, that's when you get bit with infection. That's when you get into that spiral. So if you're worried about stability, address it at the time. This system allows you to be liberal with fixation and liberal with stability between metaphyseal fixation, as well as going easily from a TS to a hinge. So address the problem that you're going in there, have a plan A, B, and C, and be liberal with both stability and fixation.
Well, first of all, thank you very much. Great panel, great discussion tonight. I want everyone to know that this will be within 2 days on our YouTube site and on our website, and also on Spotify, just in case you have nothing to do and you want to listen to this on the way home. But I'll say goodnight to everybody, and thank you so much.